diagnostic workup for patients with pancreatic cancer will start with how they present. So for our patient, he presents with liver enzyme abnormality. He's jaundiced. His bilirubin must be greater than 3 because he's jaundiced. So we'll start with simple chemistry, complete blood count, seeing whether or not he's anemic. Does he have leukocytosis in reaction to the tumor? And then we'll move on to additional blood work that might include tumor marker, CEA, and CA19-9. Just a note on CA19-9, not a great screening test. It depends on the patient having a Lewis antigen. If they don't have a Lewis antigen, they will not express CA19-9. So many times we're left with the quandary of you've got a mass in the pancreas, lesions in the liver, but the CA19-9 is normal. It's because the patient does not have a Lewis antigen. And so that's why their CA19-9 can be a little confusing. It's not carcinoma unknown primary, it really is metastatic pancreatic cancer. What other diagnostic studies are performed? Well, we move on to our imaging evaluations. We do a CAT scan, ideally with IV and oral contrast. Sometimes you won't see the mass in the pancreas, and you have to do a pancreas dedicated CAT scan, which takes more slices through the pancreas and really delineates what is normal and what is abnormal in the pancreas. Many institutions will do MRIs, again, really getting a close look at the pancreas. And then obviously we're looking at the liver, we're looking at the lungs, and we're also trying to look at the peritoneum for metastases. Other imaging studies are PET scans. PET scans are useful, I think, in the very beginning, especially when we're trying to find out if a patient is resectable and trying to find occult metastases. So PET scans are useful in the diagnostic evaluation. They may not be so great in terms of restaging patients. Other diagnostic procedures are endoscopic ultrasounds, where our gastroenterologists get involved, go down into the stomach, look at the pancreas, and are able to retrieve tissue. ERCPs are important for symptom relief, also to get some brushings. And then we move on to other studies, more advanced evaluations, especially if we don't have a diagnosis or we can't get tissue. Ideally, if you do have a patient with metastatic liver disease, you go after a biopsy of a lesion in the liver. Those are most easily approachable from a percutaneous approach. And so those are some of the diagnostic studies that we'll do in the very beginning. So an additional diagnostic evaluation is whether or not to do a laparoscopic evaluation. That's really for patients who you're considering to resect or potentially you believe have curable disease. And that's a great way for the surgeons to assess, is there occult peritoneal disease that's not picked up on imaging, and enables us to really fully stage the patient. And obviously, if there is something that they detect, they can go on it and biopsy it.